people are not looking at the obvious?
I don't want to blame the cardiologists and say that they're not looking at the obvious. It's something that they are not familiar with. They feel that it's really the purview of the primary care doctor to look at the patient more holistically and refer for a sleep study. For example, a GI doctor notices when he's doing an endoscopy that the patient is sedated. He has anesthesia with him to look after the airway, and he notices that the patient's oxygen saturation went down. They had to bag him and he recovered, and they tell the patient, oh, by the way, we think you've got severe sleep apnea. Why don't you go back to your primary and get a referral? They will not take it upon themselves to make the referral.
What if breathing is the missing link? Welcome to Breathe, Sleep, and Smile, where our breathing, sleep, facial growth, and health connect. This is the airway conversation, beyond buzzwords and connecting the dots that are often missed. Well, welcome, Dr. Desilva, my good friend Bertrand. Known you for a while. How things going?
Very well, thank you. Thank you for having me here today. I appreciate your invitation and the ability to participate in a good conversation today.
Absolutely. I first time that I heard you spoke at one of our mini residency. This is years ago. It had to have been like 12 years ago or so. And you gave such a fantastic perspective on the whole topic of obstructive sleep apnea. I think it was titled something obstructive sleep apnea, a cry for hope. And what I really loved was that story of how you explained what had happened to Dick Cheney. Being in this system, I don't know if you remember, but being in this system where he kept on being treated for cardiovascular problems. No one's really looking at sleep medicine. So I think, it went from, pulmonary hypertension to, whatever, arrhythmia, eventually turned into AFib, and then he was on a pacemaker, and there's this whole thing. I remember you talking about how the medications just kept on escalating, never really taking care of it. Do you remember that?
I do.
Yeah.
I do.
Could you maybe give a quick synopsis of it, because it does give us a microcosm of the problem.
Right. So basically, sleep apnea is the central orchestrator of a lot of the pathologies that we see, both in the office as well as in the intensive care unit. And if it's not well recognized or even investigated as an outpatient, it progresses and progresses to the point where the sleep apnea will cause pulmonary hypertension, it'll cause left ventricular diastolic dysfunction, it'll cause enlargement of the atria, and then subsequently they end up with atrial fibrillation. And the atrial fibrillation is very difficult to control because the sleep apnea is not being addressed. And even after many medications, they find that the atrial fibrillation is uncontrollable, high rate, and frequent episodes of paroxysmal atrial fibrillation with the risk of stroke. So the patients often end up on anticoagulation, arrhythmic medications which have side effects. And these side effects include bradycardia, they end up with a sick sinus syndrome, they may end up getting a pacemaker, they may end up getting repetitive ablations before the sleep apnea is actually addressed. And very recently, I had a patient referred over for evaluation of sleep apnea after having had several ablations, and those ablations were causing heart block, and he was on the verge of getting a pacemaker put in. But no addressing the sleep apnea. And when we studied him, he was very, very severe and relatively easy to treat in terms of getting his sleep apnea brought under control. And then he had a significant reduction in his heart rate and the incidence of atrial fibrillation.
It's crazy, and just for our audience, just to clarify, you're a critical care physician. You're in the ICU. You're a pulmonologist by training. And I know you're medical director, been medical director of different hospitals. So you live in the ICU, and you've lived through these problems. And would you comment on why you think this happens, that the cardiologist isn't really looking at it, or people are not looking at the obvious?
Well, I don't want to blame the cardiologists and say that they're not looking at the obvious. It's something that they are not familiar with. They feel that it's really the purview of the primary care doctor to look at the patient more holistically and refer for a sleep study. It's not their issue, their
Right.
problem.
Okay.
Unfortunately, a lot of the subspecialties feel that way. So, for example, a GI doctor notices when he's doing an endoscopy that the patient is sedated. He has anesthesia with him to look after the airway. And he notices that the patient's oxygen saturation went down really badly. They had to bag him, and he recovered. They did whatever procedure, the endoscopy, the colonoscopy, and they tell the patient, oh, by the way, we think you've got severe sleep apnea. Why don't you go back to your primary and get a referral? They will not take it upon themselves to make the referral. So GI, cardiology, endocrinology, diabetes and its management, etc. All of this is being orchestrated by the sleep apnea. Sleep apnea
Sure.
causes increase in sympathetic tone, it causes hypertension, causes cardiac arrhythmias, causes elevated blood sugar, elevated cortisol levels, adrenal fatigue has been purported to be as a result of sleep apnea as well. So all these different subspecialties are expecting the primary, and the primary is just overwhelmed. He is looking at different systems. He's trying to collate all the notes that are coming in from the different subspecialties and make sure that there's no medication interactions. But maybe he's not really addressing sleep apnea. If you look at the COVID experience and you look at the experience in the ICU, you find that a large percentage of the patients that end up in the ICU actually have sleep disordered breathing, or disordered breathing that's present during the day, but then it becomes much more apparent when they're in the ICU. And we call it sleep disordered breathing, but it's actually present 24 hours a day. They're always air hunting, they're always looking for air.
Yes.
And they end up in the ICU, and then it's too late. By the time I see them, I'm kind of flabbergasted that they haven't been diagnosed or treated, and nobody's actually thought about sleep apnea, and I end up putting them on a CPAP machine or a BiPAP machine or an ASV or what we call an AVAPS unit in the ICU. But I'd really like to fish upstream. I want to prevent them coming to that stage, coming to that status where they need the intensive care unit. They should be diagnosed much earlier, but it's a difficult situation right now.
So let's dive into that a little bit. So I'm going to suggest that part of it is the way our disease management healthcare system, because that's what it is very siloed. So it's set up not because people don't want to talk to each other, but they're so caught up in their own organ system as if these organs don't talk to each other. And perhaps, as you suggest, the primary care physician is charged with connecting those dots or whatever, but they're not, because they're overwhelmed. I think that's one problem. The other is maybe the payer system, that it's set up to where it makes it untenable for a provider to either refer with something that they're not completely sure is really happening, even though it might be, or and the last thing is, I think, as it pertains to sleep medicine in general, the focus is the tip of the iceberg. It's the end stage. It's the apnea-hypopnea index. They're not really looking at the non-hypoxic problems that are the precursors that actually eventually progress. And would you comment a little bit about how you think that may or may not be the case?
Right. So to make a diagnosis of even mild sleep apnea, the criteria that you have to meet is what we call the apnea-hypopnea index. It is the number of times that the upper airway is closed off, either 50% or more, to get hypopnea. And then an apnea is complete closure. So you have to have 5 of those events before you can diagnose mild sleep apnea. And before it can be treated as mild sleep apnea, they have to have comorbid illness. They have to have neurological issues. They have to have the possibility of attention problems, cognitive issues, etc., as well as possible cardiac issues. So if you have comorbid illness with mild sleep apnea, they can be treated with conventional therapy, which is a CPAP unit. If they're moderate, 15 or over events, then they can be treated without having a comorbid illness. And then severe is 30 or more. This criteria were really set up in 1972, which is a long time ago. When I was in my residency and training, I did not really have any exposure to sleep medicine at all. It was in my fellowship at UCLA and at Cedars-Sinai that I was exposed to this new subject called sleep medicine. It was something interesting, something easy to do. Please go through the whole fellowship and you can take your boards at the end of the 3 years. So I decided to train in that, but the way we were taught was basically that it was an old, obese male, Pickwickian syndrome. And that stuck in my mind. And I was intent on just diagnosing older men that were overweight. But what about the other gender? What about the females? What about the adolescents? What about the children? No, those populations were being totally ignored because they didn't fulfill criteria for the apnea-hypopnea index. Postmenopausal women may qualify for treatment, but a slender woman who has retrognathia, some jaw abnormalities that result in apnea, they are very, very difficult to diagnose and treat under the auspices of their insurance right now.
Yeah, I would argue even they may look perfectly normal, not even retrognathic. And I know Kristen Gimeno and Vikli Kushida, Deepak Srivastava back in the 90s looked at a series of 500 patients that had been told that they had no sleep problem. They did sleep studies, all the sleep studies, the AHI was under 5.
Right.
And they looked at it and they said they really believed these patients, of which I think almost 70% of them were female. They were relatively young, they were young to middle age, and they were normal to low BMI. And so it's somebody that would never be on your radar screen as having this condition. And so that's when upper airway resistance syndrome was defined. But interestingly, they followed those patients and they knew that they needed therapy because they weren't sleeping well. And they followed them, and 6 years later, 83% of them had still not been able to receive help from the medical system. And so those patients end up going to the primary care physician, being treated for anxiety, depression, irritable bowel syndrome, headaches for dentists, TMD problems, which are kind of the classic patients that look like a vision of health, but that have all these symptoms because they're healthy. I mean, they've got a healthy autonomic nervous system. I think that's where sleep medicine, even though it's been defined and recognized as its own nosologic diagnosis, they ignore it. I mean, it's been defined as a non-hypoxic, but they ignore it. I'm confused as to why, whether it's maybe the third-party payer or Medicare that's forcing the provider to opt into Medicare and say, you can't treat that, you got to stick to the old fat male, or, but I almost don't want to believe that.
Well, it's very, very difficult to diagnose a woman with sleep apnea, especially if she's premenopausal and the criteria are just not fulfilled. And you try to persuade the insurance company that perhaps a trial of CPAP would be appropriate, and that the anxiolytics, the antidepressants that they're on, the slew of medications that are to come down the road could all be avoided if we were to use some kind of correction for the upper airway. And it's extremely difficult to provide care for these patients under the auspices of the insurance right now. And the criteria that was set up again, as I said, for Pickwickian men. And they satisfy the criteria. It's relatively easy to get a diagnosis, it's relatively easy to treat, but those are the end stage patients. End stage is too late, right? They've already got the cardiovascular end stage. Yeah, it's too late, you know. And basically what we need to do is that we need to really basically fish upstream and prevent the progression of these disease process, and be cognizant of the fact that sleep apnea just presents differently in different genders and at different ages. The young child may develop behavioral issues, ADD, ADHD, a little bit of being on the spectrum, perhaps a little bit of autism. Maybe they present with learning disabilities and problems with behavioral management in school. Those are the children that really need to be assessed at an early stage in their lives. And then you think about the college students, the students that are constantly tired. They're talking about the possibility that they may be having narcolepsy. And if they have REM-related sleep apnea, they preferentially deprive themselves of that portion of sleep. And you do a multiple sleep latency test following what is essentially a normal, in inverted commas, a normal polysomnogram. And you find that they have REM onsets. So suddenly now they're on modafinil, Wixela, etc., etc. And you're trying to treat them for narcolepsy, which they don't really have.
They don't have it. Exactly. So let's just say, regarding the treatment, let's say we're talking about a younger to middle-aged population. The fact that the solution is CPAP, to me, is ridiculous. We already know that there's low compliance anyway. Can you comment on what you think the solution should be? Because I don't believe that you would think that a 30-year-old should be on CPAP for the following 50 years, right? Because there are side effects. Where you think the future is in really addressing, as we find out that the prevalence of this problem has increased. I mean, putting aside, you know, the Medicare and how you get paid as a physician and the lack of understanding of your specialty, what are your thoughts?
My thoughts regarding sleep is that I think it's underdiagnosed, underappreciated. The criteria are from 1970, and the medical community and the dental community both really need to address the criteria. And the way that we diagnose it is extreme. It's a very extreme end of the spectrum that we're allowed to diagnose and treat. And what we need to do is to be more proactive and perhaps use different modalities so that we can diagnose people earlier and be proactive in their treatment.
Yeah, early intervention. I did a study some years ago. We haven't published it yet, but we're in the process of doing it. And one of the PIs, primary investigators, is Uma Katwa, who runs a sleep lab at Harvard, pediatric sleep lab at Harvard. He's a pulmonologist and a sleep physician. And we were going over the data on these kids. It was 50 kids. And I was showing him using high-resolution pulse oximetry and then treating before and after, showing how the heart rate dropped. They were in distress. Their symptoms went away from early intervention, definitive treatment having to do with their facial skeleton and their breathing. And he said, clearly, the apnea-hypopnea index is not capturing the real problem with these kiddos, and that it's a problem. It's really the autonomic nervous system is overregulating, it's overshooting, because gas exchange is the most important moment-to-moment function in any mammal. And if there's any kind of flow limitation, you're going to have some kind of sympathetic response, albeit maybe low, but it's chronic. And that's what leads to chronic disease. And I know he's really has had some institutional pushback. as well as others, that they just want to stick to the criteria. It's got to be, you're not really sick until your apnea hypopnea is over 5. And so that's the future generation of Pickwickian male that snores. And it's a little bit sad, don't you think? I mean, it's...
Yeah, it is sad. Always, finding patients that are extremely fatigued, extremely tired, low apnea hypopnea index below the threshold of 5, but then we come out with this other number, which is the respiratory disturbance index, which is the apnea hypopnea index, the AHI, plus what we call the RERAs, respiratory event-related arousals. And you add those together, and they may be over 30, which is severe, but the apnea hypopnea index is less than 5, so they can't be treated with conventional therapy, at least. And a trial of CPAP was something that I advocated to try to see whether there was some clinical improvement. You don't want to pursue a diagnosis of sleep apnea to see whether there's improvement by doing something really dramatic. So using a CPAP unit on a loner basis to see whether there's clinical improvement seemed like a good solution. But I understand now that we can use the esophageal pressure balloons as well to get a much higher index, and that has enabled more patients to get treated.
Yeah, that's been my go-to, because that was the original way of really measuring flow limitation back in the 70s. Kristen Guilleneau wrote about that, where and ironically it was in the pediatric community. He was actually doing a big study looking at kids, and he used the esophageal probe to look at flow limitation. Now I think it's very difficult to get that because it's invasive. It's not, except that no one's going to pay for it. You have to have that special training, and the sleep labs, they just don't want to do it. And I think that's been frustrating, but you find patients who have an AHI of 1 or 0.5, when you use esophageal probe that is able to pick up those flow limitation nuances, that apnea hypopnea index goes up to 30 or 40, really shows what's going on. And if that helps the patient attain a letter of medical necessity for the insurance company by contract to be forced to help pay for the treatment, I think it's worth it for the patient. But it's sad that you would have to go through that. I don't know what the solution is. I am concerned with long-term CPAP. With the recent studies in the last 2 years that actually shown that due to pneumatically stenting the airway open, there's an upregulation of angiopoietin, which is cardiovascular risk. It downregulates VEGF, which is cardioprotective. And so I don't know where we are on the studies actually trying to suss out what's going on there. I don't know if you've read that or have heard that, but that long-term use of CPAP can be harmful. And one of the reasons perhaps that they didn't find a big changes in cardiovascular morbidity
and mortality, yes.
Yeah, part of it is that there's only 30% compliance, right? And then when they use it, it's the first half of the night versus the second half, right, when it's most risky. But maybe some of it also are these cardiovascular regulators that may be harmful, because you're stenting the airway open, and it causes the stretch receptors to release these factors that turn out to be cardiovascular risks. But I don't know what your thoughts are about that.
Yeah, I haven't read a lot about that right now. And I know that there's been studies done on CPAP usage, compliance, as well as whether it reduces cardiovascular mortality and morbidity. And there is really no good medical evidence for CPAP usage, except the patients do feel better if they use it. Yeah.
Some of them do. That was actually published in the New England Journal of Medicine. They did a follow-up to the Wisconsin cohort looking back, and that's what they found. They found that it was related to hypertension as well. I don't know what that solution is. For me as a dentist, I want early intervention, and if you really understand the risks to our children very early on, having to do with all the things that you listed, the cognitive problems, the ADD, ADHD, which really they don't have. It's just they're not sleeping.
Right.
And Dr. David Gozal, who now is at physician in chief in West Virginia, actually showed that the immune system takes a hit, and that cancer incidence goes way up as a result of just sleep fragmentation. And he actually, he and others, Nieto from Spain, actually said that obesity is causal for cancers. And obesity is really a finding of long-term sleep breathing problems. It's not the cause of it. And yet sleep physicians oftentimes say that lose some weight, you're going to do better. I think you're going to do better, but I don't believe that it's the cause. I believe it's a comorbidity of the individual being in chronic low-grade breathing problems, and upregulates sympathetic drive. They become fat.
Right.
They aren't born fat. And it's not just the food supply. I mean, it doesn't help to have, the food supply that we have, but because I know when I treat my patients, they do nothing else different. I see them a year later, and they've just dropped the weight without being on a GLP-1. So I don't know if you've noticed that if patients get on CPAP, you notice that they drop weight.
They have a drop in their sympathetic tone, for sure.
For sure.
The adrenals are not being constantly stimulated by the apneas, and they're not constantly releasing cortisol. Right. So it's not just an adrenal issue in terms of release of sympathomimetics. It's basically a question of cortisol release as well, and that can be alleviated by treatment of the sleep apnea. So weight loss does follow treatment.
Yeah, that's because you regulate metabolically. It's during N3 sleep the hypothalamus releases glucagon, insulin, the sex hormones, growth hormone, and if you're not getting enough N3 sleep, you're not releasing it because it releases it in spurts of 7 to 9 minutes, 3 to 5 times a night. You're just not getting it because it's what do you see? Tell me what you think about this. I believe it was Steve Park and others have actually stated that, and there are others that have stated that women in the third trimester of pregnancy, almost all women have sleep disordered breathing. And it makes sense because it's kind of like the hypoventilation from having this big mass in your belly, just like, the Pickwickian male.
Right.
And they are very uncomfortable. So they're moving around trying, and there are studies to actually show that the cortisol that results from that has downstream consequences to the fetus. Small for gestational age, increased risk of preeclampsia, increased risk for gestational diabetes. When I talk to a mom that's pregnant in the third trimester, I suggest that they should either have an oral appliance or CPAP temporarily during that period. What are your thoughts about that? Does that make sense?
That makes a lot of sense, actually. I saw a patient about a week ago that had been referred, and the funny thing was that she was at risk already because her father has sleep apnea. Mm-hmm. And so genetically she was predestined to have sleep apnea. It just came on faster with the pregnancy. And one of the issues is that she had a previous pregnancy and had also suffered from eclampsia where she had not been treated. On this occasion, she wanted to be treated aggressively. CPAP, whatever, dental device, just so that she could go through the pregnancy and not have the complications as a result of the sleep apnea exacerbating her hypertension, as well as having a more restful sleep, for sure.
Yeah, I don't. That makes sense. Now, we're friends, so I don't want you to get mad at me when I say this, but I'm going to argue and push back that there's no evidence to support that if a parent had it or grandparent have it, that you have, that's actually genetic. I believe there's strong evidence that it's epigenetic, that you acquire this condition. We never had this condition, well, first of all, obesity was relatively non-existent 200-300 years ago. It really wasn't. We changed our food supply and all that. But I think we tend to say things are genetic because they run in families. But I think also what runs in families are, cultural norms of this is the way you eat, this is what you do. Yes, you might have similar facial skeletons because you look like your parents, but there is a lot of evidence to show that that the way we are developing has changed dramatically in the last 500 years, and that results in smaller nasopharynxes, smaller airways that are risks for flow limitation. On that, I don't know if you have a comment on that or what your thoughts are, because you're kind of strict critical care sleep physician, right?
Right.
Yeah.
So I have my thoughts about diets and GMOs and extraction of teeth, extraction of wisdom teeth, extraction of premolars to get that perfect smile.
Don't let the orthodontist hear you.
But it's I think we're predisposing ourselves to all the chronic problems as a result of sleep apnea by not addressing these issues at an earlier age. We need to address things much, much earlier than what we're doing right now.
So if we could just follow that line of logic, because it totally makes sense. So if we're extracting teeth, let's say you're an orthodontist, you're extracting teeth to straighten the teeth out, why not ask the question why there was crowding to begin with? Because there's no set of alleles that call for dental crowding. So dental crowding is really a solution for Mother Nature to a problem, where there wasn't enough development of the arches, there wasn't enough growth. Anthropologically, we go back, it just never happened in any population anywhere around the world unless it was a diseased population, usually the bourgeois or the very wealthy that had a lot of wherewithal, that was kind of westernized, that didn't allow for good growth and development. But we just never saw it anthropologically. So doesn't it make sense if you're extracting teeth, maybe the problem already existed, but it was subclinical, not recognized, and then you make it worse by retracting, and then now you have even less airflow. And so that's the way I think of it, is that it's really treating a symptom, chasing a symptom that makes a pre-existing condition
worse,
even worse.
Right.
I remember this study, this may be similar, and this is what we do in sometimes in evidence-based reductionist thinking. I remember a physician, well-known physician who was on TV talking about a study that had just come out saying that the use of diphenhydramine for sleep, that people will use as a sleep aid, had been associated with an increased risk of Alzheimer's or presenile dementia. I remember thinking about that, going, isn't that interesting? Isn't it maybe possible that the reason why they had the Alzheimer's is because they couldn't get good sleep and they were taking a medication to get them to go to sleep, and what ended up happening is it just played out. So they're making this association of a medication creating the risk, but it was already there, and the patient was just trying to solve a problem, which was to sleep, but they weren't able to sleep for whatever reason. Does that make sense? Maybe it's a little bit of that. We have to be careful, but...
Right, the chicken or the egg situation.
The chicken or the egg, right.
Right. And I think that developmentally, children who are not given adequate feedings, breastfeeding, for example, is much more laborious for the infant than is bottle feeding.
Yes.
And jaw development is affected by what type of food the child gets, whether it's breast milk or whether it's artificial milk,
Yes.
right? And so I think jaw development is affected, especially in the Western countries, which have a propensity towards feeding the children non-human milk,
Yes.
basically.
But do you think it's what's actually in the milk, or is it the action of how you draw the milk?
I think it's the action of drawing the milk.
Exactly.
Yeah.
Right. People. It's less about what's in the food, although that's important. But you have to challenge those muscles very early on, and then it starts stimulating, compensations, and I say it's this downward spiral. Then you go to soft foods, and then they have texture version. Then they only want to have chicken tenders and fries. But Dr. Desilva, tell me what would be your nirvana as far as like what would you like to see, as a pulmonologist, critical care sleep physician? What would you like to see if you could change the system that you think would help the public's health in general as it pertains to sleep apnea or sleep disordered breathing?
I think from a epidemiological situation or making a huge change, I think that we should go back towards breastfeeding.
Mm-hmm.
I think that's one of the major issues. Breastfeeding, I think, would improve jaw development, musculature, etc., etc. I think dentists are much more aware of sleep apnea than some physicians are, and that is because they see the airway all the time, and I think they're cognizant of the fact that they may be making things worse by extraction of teeth.
Mm-hmm. Yes.
And so I think that I don't like using jaw expanders very much because I think it's very uncomfortable for the children. But on the other hand, if you can prevent long-term complications by using the jaw expanders.
They're really not uncomfortable at all.
No?
No, they don't have any discomfort. In fact, they find relief. As soon as you put it in there, they kick and scream for a few minutes, and then I'll see them even a week later. They don't even know it's in their mouth. But mom will say, "Oh, he's not tossing and turning. He stopped the bedwetting.
Okay.
He's not sweating. He's a different kid in the morning. He gets up." So yeah, I think that you would think it would be, but it's not uncomfortable. It really isn't, Dr. Desilva. And if it has lifelong consequence, in fact, I think when we were in the green room, you were telling me a couple of stories, if maybe you could share regarding a couple of situations where a patient came in and was upset at you, and could you tell us, what I'm talking about?
Yes. So the way that I was educated, only adult men who are overweight have sleep apnea. And there was this lady that came and met me at one of the clinics and was determined to get a sleep study for her 15-year-old son. And what was the complaint? Well, the complaint is that he won't get up for his Saturday job. He won't go and work at Jack in the Box on Saturday morning. It's very difficult to get him out of bed to get to school, very difficult to get him to get out of bed to go to his job. He just will not get up. And I was not in a mindset where I was going to accommodate her by giving a sleep study to a 15-year-old, especially when I knew I had been trained that it was going to be a obese older man that was going to have sleep apnea. I left her in the room. I went around, saw all my other patients, came back again, she's still there. Did another round, came back again, she's still there. On the third round, I relented and ended up actually ordering a sleep study on a 15-year-old, which was so much against what I had been trained. And it came back, and it wasn't just mild or moderate, it was nearly severe. It was 25 apneas and hypopneas an hour.
Wow.
And I was just overwhelmed. I could not believe that I could be so wrong clinically, that I didn't suspect that he had sleep apnea. Treated him, put him on a CPAP machine, and this young man just disappeared. And I didn't see him for a long time. And I was coming out of a movie theater after having seen a movie called Fast and Furious, and it was at the time that there had been some assaults in the movie theaters. So I was coming out and I get accosted by a group of teenagers, and I'm feeling rather fast and furious myself at that time. And I was getting ready to have a confrontation. And these individuals said, no, don't get upset. This young man is actually your patient. And I didn't fully recognize him. And subsequently, I found out that he had gone to one of the university centers and had maxillofacial surgery for his sleep apnea. And he had a tremendous improvement in his educational trajectory. He had been failing everything, not being able to get up. He was falling asleep at school. Suddenly, treatment had resulted in an acceleration of his intellect. He was now in pre-med, and he was going to do medicine and actually start to do sleep medicine. That was his aim in life, and I was just overwhelmed that a treatment which I thought was a relatively minor intervention could have such a profound effect on a person's educational trajectory and their achievement in school. Was not aware that could have such a profound effect. And since that, I suppose, intervention by his mother on my treatments, I'm much more open to evaluating younger children, adolescents, even younger females, in terms of their sleep and their sleep disorder than I would have been if I hadn't had that experience.
Yeah, wow, that's in my experiences, I have those stories almost every day in my staff. Some of those, there are days where people are crying. Patients come in, super rewarding, but at the same time, people could be angry.
Yes.
How was that missed?
How was that missed? So another story, not a very pleasant story for me, but I had a patient that came in with end-stage colon cancer. It was metastatic. He had hematemesis and hematochezia, and he was found to have metastatic colon cancer. And the liver was full of it. So I needed to talk to the family. I gathered the family, and I was talking to them. And the oldest son would fall asleep during this very, very important discussion, and I felt kind of hard done by because he wasn't actually listening to what I was saying. Anyway, at the end of the conversation, I told him, look, I can help you, but I can't really help your dad. And I organized for this patient's son to end up getting a sleep study, and I was very enthusiastic when he was going to come into my office, really wanting to see what the outcome was. And he came in, and I hugged him and said, how's things going? And he says, they're going terribly. So I said, why? I'm so sorry about your father. He passed away. And he said, no, it's not about my father. It's about me. So I said, well, tell me what happened. He says, well, I've been complaining of sleepiness and being unable to stay attentive at school since about the age of 15. I'm now 35. I come in to see my father who's passing away. You look at me for like 2 minutes and you say, oh, I know what's wrong with him, I can treat him. But where were you 20 years ago when I needed you? I didn't pass my educational goals. I didn't get my GED. I work as a janitor, and I'm at risk of losing my job because I keep on falling asleep. And it was heartbreaking. And he was crying and angry because of a lack of diagnosis. And that's what we're facing right now.
Yeah, it's poignant. Yeah, I think our responsibility to our patients, but the population at large, has to refocus on a bigger picture beyond, as you say, that Pickwickian fat snoring male who don't want to be on CPAP anyway because it doesn't bother them that they're snoring. It's just their bed partner. It's the next generation of chronic disease. And Dr. Desilva, I really appreciate you coming in and participating in this podcast. I have a lot of respect for you. I know you're an excellent sleep physician. You really care about your patients, and we've become friends through the years. And I want to continue to collaborate with you. I want to continue to try to change the environment, make it easier for other providers, first to understand, and then also to work within a system that's somewhat broken. And I know you've got so many interesting stories in the ICU as well, and I know you went through hell during COVID. So I'm so glad that that's over and that you are focusing more on sleep medicine.
Right.
Because I know critical care will grind you up and spit you out. And you deserve to practice for a long time. So thank you very much for that.
Thank you.
Yeah.
Appreciate it.
Thanks.
Thank you for inviting me.